Auz billah min shaitanir rajim. Bismillahir Rahmanir Rahim. I welcome all the participants for today's session, which is evaluation and management of dyslipidemia. Today's talk will be delivered by Dr. Umair Ali. He is a senior registrar of Khyber Teaching Hospital, Peshawar. He is MBBS, FCPS cardiology, as well as MD in cardiology as well. So I would request Dr. Umair Ali to take up the session.
Hopefully my voice is coming to you people. Assalamu alaikum. My name is Dr. Umair Ali and I am working as a senior registrar at Khyber Teaching Hospital Cardiology Department. I have done my MBBS and FCPS cardiology from Peshawar, and I have done my MD in internal medicine from United States of America. Moreover, I have also worked as ex-managing editor of Pakistan Heart Journal, which is the official journal of Pakistan Cardiac Society. Today, we are going to give introduction and as main theme of the dyslipidemia and how to evaluate and manage dyslipidemia. We are going to discuss the guidelines. My presentation will be guideline directed so that you people are in a good position to see and to know about the dyslipidemia. First of all, what is dyslipidemia? If you see that hyperlipidemia, hyperlipoproteinemia or dyslipidemia is the presence of raised or abnormal LDLs. Basically, the cholesterol is of two types or three types. One is the LDL, one is VLDL, and one is HDL. The bad ones are the LDLs and VLDLs, and the good one is the HDL. So our main focus will be between the LDLs and HDLs. So if you see that dyslipidemia is basically classified into primary and secondary. The primary is always the familial type. It is that type of dyslipidemia in which the patient presents in early age, round about at the age of 16, at the age of 20, 21, the patient is quite young. And there are first and two generations. 1-2 generations history of dyslipidemia and the complications related to this dyslipidemia. Dyslipidemia is actually the bad cholesterol. आप कह सकते हैं बुरा cholesterol, जिसकी वजह से patient को problems होते हैं. And the other one is known as secondary or acquired. Secondary or acquired ये है कि patient is having some type of problems and after that it is developing the dyslipidemia. So, जैसे कि I have already told you that the primary dyslipidemia is single or multiple genetic mutations, and these genetic mutations have basically the disturbance in the receptors or the production or the excretion of the LDLs, HDLs or TGs, which is the triglycerides. So you have to suspect the primary dyslipidemia in a patient who is having a premature heart disease, as I already told you. Then family history of the atherosclerosis, about 1 or 2 generations having the primary dyslipidemia. Then total cholesterol level of more than 240 mgs. We will talk in mgs, not in millimoles, because millimoles are more pertinent to UK as compared to USA. So the physical signs of dyslipidemia. In a next slide, I will show you some of the signs of dyslipidemia. So whenever you see a patient having these type of signs, you first of all go for the lipid profile. So these are the signs. One is known as xanthoma, other is known as xanthelisma. Xanthoma basically क्या है? Xanthoma is that there is deposit, the deposits of the lipids, the deposit of the lipid droplets, which are very obvious on the skin. These deposits basically जितने joint and tendons होते हैं, tendons and joints, they call the deposit of these lipids, and this is known as xanthoma. So one of the signs which you see in a patient of dyslipidemia is xanthoma. So always check the joints, the knees, the Achilles tendons, so the elbows, the wrist joint, the fingers, you will see these types of marks. And xanthelisma, आपने बहुत से old patients देखे होंगे, तरफ आते होंगे, तो उनकी आंखों पे आपको ये yellow dots मिलेंगे. This is known as xanthelisma. So one is xanthoma, other is xanthelisma. Both of them are the physical signs for dyslipidemia. Another thing is arcus senalis. Arcus senalis पे मैं इसलिए ज़्यादा बात नहीं करूँगा क्योंकि ये old age में ऐसे भी आना शुरू हो जाता है. It is basically the round hollow which is present in the iris of the patient. So we will not consider arcus senalis as one of the sign of dyslipidemia, as it is obvious in the old patients also. So we will focus basically in examination on xanthomas and xanthelismas. So हमें पता कैसे चला कि cholesterol is a bad thing? It was because of this Birmingham heart study, the vast study, and on the basis of these studies, risk scoring was made, which is known as Birmingham heart risk. And on the basis of these heart tests, till about 2016-17, when ASCVD risk score came into being, this was the Birmingham risk score, which was the main focus. And here we see at the passage of time and the total cholesterol increases, the incidence of the cardiac heart disease also increases. As you see from here, that it starts from less than 204, and then it goes up and up and up. If the patient is having more dyslipidemia, there is more chances of contracting the coronary heart disease. जैसे कि मैं आप लोगों को ऑलरेडी बता चुका हूँ that there is primary dyslipidemia and secondary dyslipidemia. The secondary dyslipidemia, it causes increased LDL and increased TGs. There are certain type of diseases like obesity, hypothyroidism, diabetes, nephrotic syndromes. Sometimes pregnancy causes increase in the TGs and LDLs. Anabolic steroids are more used nowadays when the patient or the people are using it to gain the muscle mass. So these are the things which are causing increase in LDL and increase in TGs. Both of these things are dangerous. We are more concerned with the LDL, the low density lipoprotein, because it is the one which is more focused for the coronary heart disease, whereas triglycerides are more concerned with the acute pancreatitis. But both are bad and we have to control them. So these are certain, you say, if आप एक patient देखते हैं who is obese or hypothyroid, having liver disease of nephrotic syndrome, or if any kind of medications like cyclosporines or anabolic steroids, so do take the lipid profile into consideration. ATP3 guidelines. ATP guideline, as I already told you in the beginning of the presentation, that my presentation will be guideline directed. So अगर आप इन guidelines पे करें, तो the guidelines have changed a bit. In this guideline, latest guideline, they have mainly focused on Southeast Asia. They have mentioned the name of Pakistan, India, Sri Lanka, Nepal, Bangladesh. So they have mainly focused on Southeast Asia because we are very reluctant to use statins. We are not very good in using statins because हम डरते हैं कि कहीं ये ना हो जाए, हम छोटे कद के लोग हैं, हमारे बॉडी बिल्डिंग उस तरह की नहीं है जिस तरह के अंग्रेजों की होती है या whites की होती है. So that's why we are always reluctant to give high dose of statins. We are always reluctant to give any type of medication to this population, and that is the main reason that they have introduced ATP3 guidelines. ATP3 guidelines are basically the National Cholesterol Educational Program for Adult Treatment Panel. This is called Adult Treatment Panel ATP3. According to these guidelines, they have said that if there is any person without any type of disease and he is more than 20 years, you have to have a baseline lipid profile done for him. हम में से कोई नहीं करता, but you have to do it. It is the protocol, standard protocol. If the patient is having age of more than 20, you start with the lipid profile. After that, if the patient's lipid profile comes to be normal, it doesn't matter whether it is fasting lipid profile or it is random lipid profile. If the lipid profile comes to be normal, then check it every 5 years. And if there is any abnormality, then check it yearly or treat it. Okay? Fasting, बाज़ लोग कहते हैं कि हम fasting करें कि non fasting करें, it doesn't matter. Actually, trick is that if you get a lipid profile done on a patient who is 21 years of age, and the profile is going to say that the total cholesterol or LDL, HDL are normal, then nothing to worry. Straight away, stick to that random lipid profile. But if the patient's TGs or total cholesterol come too high, then it is recommended that you should go for the fasting lipid. And the fasting lipid will tell you the actual lipids of the patient, because you have to segregate whether the patient is having primary dyslipidemia or the patient is having secondary dyslipidemia. For that reason, at the age of 20, you have to do the lipid profile. And mind it, it is for the Southeast Asians, and also they have included women this time. And this is endorsed by AHA. This is okay. If you see that the preventive services task force recommendation, if the patient is a man and having age of more than 35, or the woman having age of more than 45, and they have not done the lipid profile at the age of 20, you have to do it. Then, if the patient is having the cardiac disease risk factor increases when the man is more than 45 years old without any secondary cause. For that, you have to look for the prior cardiac disease, abdominal aortic aneurysm, peripheral arterial disease, carotid disease, paraplegics, diabetics, hypertensives, smokers, obese. These are all the risk factors. These are the risk factors which are not embedded in ASCVD risk score or pool cohort studies. These were also mentioned by Birmingham heart study, but these are the main risk factors which have to be focused and which have to be addressed by a doctor, and to see if the patient is having a heart disease or the patient is having equivalent to heart disease, which is diabetes, which is peripheral arterial disease, which is coronary, which is carotid artery stenosis. These are all equivalent to the cardiac heart disease, whereas smoking, family history, and obesity should also be considered. And these are the main focuses where you have to go for the lipid profile. Now here we come for a case discussion, and I will ask you that if a patient is a 58-year-old man who is hypertensive, non-diabetic, is not a smoker, and he had a minor stroke 3 years ago, which is known as TIA, and his total cholesterol is 182, and in total cholesterol you see that LDL is 92 and HDL is 38. What will you do? How will you manage this patient? If this is the scenario, the first thing which comes into mind is this. Our statins recommend, whenever you are treating a patient like this, we will come back, that if you are managing a patient which is 58 years old, hypertensive, having LDL of 92 and HDL of 38, the first focus will be to control the lipid profile. And in the coming slides, this will be made clear. According to guidelines, there are 4 groups in which it is mandatory to start the statins. One of them is patient is having clinically coronary artery disease, patient of MI, patient of angina, patient of unstable angina, and patient having coronary artery disease. These are the clinical ASCVD. Then, if the patient is having low density lipoprotein of more than 190 mg, irrespective of any other thing, you have to start the patient on statins. If the patient is a diabetic and having an age of 40 to 75 years, you have to start on statins. And if the patient is having 40 to 75 years and he is having risk factors for the CVD, and the risk factors calculation came to be more than 20%, then you have to start the patient on statins. So 4 groups. 1, patient of coronary artery disease. 2, patient having more than 190 LDL. 3, diabetic patient. And number 4, diabetic with high risk factors like smoking and family history and obesity and hypertension and all of the risk factors for the cardiac disease. So keeping that scenario in your mind, we will start with the statin. Now, how to dose my patient? Yes, CVD, carotid artery disease was there. If you remember, TIA was in the history, patient was 58 and a man. So it is more than 45, a male patient with a TIA, you have to start him on statins. This is the secondary type of dyslipidemia. So the important thing is what is known as cardiovascular disease, as you all know, and I have already mentioned about that history of MIs, acute coronary syndromes, stables and unstables anginas, and strokes and peripheral arterial disease, carotid artery disease. All of them come in the cardiovascular diseases. If the patient is having any type of these things, then there is no need of any assessment. Straight away go for these statins. Whereas another classification which is very much mentioned in this ATP3 guidelines, this is known as very high risk or stable ASCVD. So what is meant by very high risk? Very high risk is that patient having 2 or more major events on one major event plus 2 or more high risk conditions. Major events, what is meant by major event? This is acute coronary syndrome within 1 year, myocardial infarction, ischemic stroke, symptomatic peripheral arterial disease. These are the major cardiovascular events. So if the patient is having major cardiovascular events, 2 of them or 1 major and 2 high risk conditions like obesity, hypertension or any type of this thing, then the patient is considered very high risk. Straight away go for the statin therapy. Whereas for high risk conditions, these are age more than 65, patient is having CABG, PCI, diabetes, hypertension, CKD, smoking, and all of the risk factors which are for the cardiovascular disease. This is known as high risk conditions. So very high risk and high risk, all of them for the cardiovascular diseases. Okay. Okay, now उम्मीद है अब आवाज पूरी हो रही होगी. Okay, let's see. Now age is no statins for the stable coronary disease. Age of less than 75 years, you start with high intensity statins. And if the patient is more than 75 years of age, start with moderate intensity. If the patient is tolerating it, go for high intensity statins. Patient cardiovascular disease, high intensity statins is recommended. Patient less than 75 years, continue with high intensity statins. Patient more than 75 years, start with moderate intensity, switch to high intensity. If the patient is having tolerability, then continue with high intensity. Otherwise, stick with the moderate intensity. So it doesn't matter if the patient is old or not old, statin is the main focus for the cardiovascular diseases. Now, what is meant by high intensity statins and tolerable intensity statins? So, according to definition, high intensity statins, if the statin level at the baseline is reduced up to 50%, then you have achieved the focus of the high intensity statins. And if it is lowered to 30 to 50% and less than 50%, but more than 30% reduction, then this is the focus of the moderate intensity statin. And for low intensity, it is less than 30%. So what the dosage is needed, if you are going for high intensity, it is Rosuvastatin 20 to 40 mg and Atorvastatin 40 to 80 mg to reduce it to 50%. If you want to reduce between 30 to 50% moderate intensity, the dosage is Rosuvastatin 5 or 10 mg and Atorvastatin 10 to 20 mg. And for the low, it is already known 5 mg or 10 mg. But statins are not coming into this lower group. Actually, the lower group was made for the simvastatin, because simvastatin has a lot of side effects. So simvastatin is still used, widely used in the world. So that is the main reason that they have put a group which is known as low intensity, and simvastatin 10 mg is in it. Now, if you are starting a patient on these statins, what prerequisites you need? Actually, if you know that statins have two major problems. One is with the liver functions and the other is with the creatine kinase or CK, that is the muscular myopathies. So it is better, before starting a patient on any statin, go for a liver function test. Then CK levels can be measured if needed, and renal function test should also be done. So these are the three prerequisites before you start any patient on these statins. Once the liver enzymes have been checked, then there is no need to recheck them unless the patient becomes jaundiced or the patient is having abdominal pain or the patient is having pale stools. Then you have to check it again. The other thing which I already told you, that is CK. CK depends upon the personal or the family history of the statin intolerance, clinical presentation of the myopathies, myopathic disease is there, patient is having aches and pains, and patient is on high intensity statins. Go for the CK. If the CK is raised of more than 50%, then you can stop the statins, give some time to the CK, recheck it, and again start with the same intensity. The other protocol is that if the patient develops signs and symptoms of the myopathy, you continue with a low dose of these statins and then reconsider the CK. But this is very low, about 0.1% of the patients in the whole world have given the history of any CK problem or myopathies. So nothing to worry that much about it. How to follow up after starting statins? Ideally, if you start a patient on statin and the patient is having a dyslipidemia, check a fasting profile 1 month after the treatment of the statin. Then every 3 to 12 months. But my protocol is that I start a patient on statin and after a month I check the patient. If the patient is doing well, or the patient has achieved the target which I want to achieve, then there is no need to repeat it. Then I repeat it about 3 months or 12 months after the a monthly lipid profile. Okay, and as I have already told you that high intensity reduces the LDL to about 50%, and moderate intensity reduces about 30 to 50%. We will focus between high intensity and low intensity because it is the main thing which you want to achieve for treating a patient on the cardiovascular disease. So baseline lipid profile, check it after a month, then check it after 3 months, and check it yearly. Okay, for liver enzymes, if raised, recheck it, stop statins, and look for the other causes. For the CK, if the patient is having family history, patient having myopathy and signs and symptoms, stop statins, check for CK, give some break, again check, and then you will find out whether it is because of other things or it is because of these statins. Now, the main focus which we already, or the main question which we come across during our clinical practice is which statin is present. Are you going for rosuvastatin? Are you going for atorvastatin? Someone is prescribing pravastatin, parvastatin. Every statin has its own beauty. Atorvastatin was the one which came after simvastatin, and because of its safety profile, it came and boomed like anything. And this atorvastatin was then held by the reins because of the rosuvastatin. So we will focus what to do. Are you going to start patient on rosuvastatin? Are you going to start patient on atorvastatin, or are you going to start a patient on simvastatin? So these are the questions which we as medical professionals really discuss. So I will try to clarify on the basis of evidence that which one is better and why. If you see this slide, if you already know that statins are basically HMG-CoA reductase inhibitors, so they stop the production of the cholesterol, and in that LDL is used more and more, so it causes the reduction in whole of the body. Here, it was studied by McTaggart et al. That the minimal inhibition concentration is the minimal dose required to achieve your target, to reduce to stop HMG-CoA reductase. So if you see rosuvastatin 5.4 achieves that target as compared to 8.2 mgs of atorvastatin. So rosuvastatin, if you compare in case of the dosage, it is superior to atorvastatin. And if you see the simvastatin, it is 11.2, yet you have to give 11.2, about twice the rosuvastatin. The simvastatin dosage should be given to achieve your target and minimal inhibition of about 50%. Now we talk about pharmacokinetics. Statins, if you see rosuvastatin, it has no food effect on the bioavailability, while others have, against simvastatin. Atorvastatin decreased by 13%. If you do with the hepatic excretion, yes, so hepatic extraction about 90, whereas it is 70 for the atorvastatin, and for simvastatin it is about 78 to 87. The beauty is that metabolic enzymes, you all see that P450 enzymes are basically used, and P450 system is the one which causes the interaction between the different drugs and causes inhibition and activation of the system, and acetylation, which causes problem for the availability. Here it is 2C9, 2C19. 2C9, 2C19 is very much different from the others. If you see flavastatin 2C9, this is the basic thing, 3A4. These are the things which cause interaction more as compared to 2C9, 2C19. The half-life is about 20 hours, which is a good thing for the rosuvastatin as compared to atorvastatin, which is 14 hours. So OD dose is basically recommended for that. We are talking about statins, but what is the benefit of these statins? The benefit of the statins is to stop or reduce the risk of the coronary heart disease. The main focus is coronary heart disease. So reduce 1% reduction in the LDL causes 1% reduction in the CHD, and 1% increase in HDL decreases the risk. 1% was 1:1, 1% decrease in LDL, 1% decrease in CHD, 1% increase in HDL, 1% decrease the risk of CHD. So that is the reason we are focusing on the statins. One of the major trial which was done on the statins, which are known as Stellar trial. In Stellar trial, they basically compared the dosage of rosuvastatin against different other products like atorvastatin, simvastatin, and pravastatin. So it was basically focused on the dose. that which dose will cause maximum effect and maximum benefit to the patient. If you see the purple line of the rosuvastatin, the 50 low dose is causing an LDL above 55%. Yani it decreases more as compared to atorvastatin. You need high dose of atorvastatin as compared to the rosuvastatin to achieve your target of about 50% reduction in the LDL. Here again the same thing. If you want to reduce 50%, rosuvastatin 10 mg is comparable to atorvastatin 40 mg. And 10 mg of rosuvastatin is compared to 80 mg of simvastatin. So it is better to start with a drug who is having a low dose, causes less side effects, and achieve your target in a minimal dose. So rosuvastatin is better as compared to atorvastatin and simvastatin according to Stellar trial. Same thing again, the LDL from baseline reduction, 10 mg was the focus in this study, in Stellar trial, and they said that the 10 mg causes 45% reduction for rosuvastatin. For atorvastatin, it causes about 35% reduction, and for simvastatin, it causes about 30% reduction. So for simvastatin and atorvastatin, you have to go for higher doses to achieve what is achieved by low dose of the rosuvastatin. Same again thing that the patient's achieving the goal. It is basically a 10-year cardiovascular patient having secondary dyslipidemia, and you start the patient on the statins. Now, what dose of statin is comparable to the other doses? Here you see that the low dose of which is the rosuvastatin 10 mg, which is compared with the atorvastatin 10 mg. So there is a quite difference. If the patient is having less than 20% risk or patient having high risk, you see that rosuvastatin 10 mg is much better than 10 mg of the atorvastatin. To achieve the same goal of the rosuvastatin, you have to give atorvastatin about 20 mg or 40 mg. So that's the reason, increasing the dose, you will get increase in the side effects. So rosuvastatin achieves the European Society. We talked about the American Society. Now the European Society also caused a reduction with the minimal dose of the rosuvastatin 10 mg. So the Stellar trial was basically meant to compare the doses between the different type of among the different statins. Here we focused on the LDL. We said that 1% reduction in LDL causes 1% reduction in CHD. So 1% increase in HDL causes 1% reduction in CHD. So that is the reason, which is very much obvious in this. If you see that the patient starts from the 10 mgs and goes up to the 40 mgs for the rosuvastatin, the HDL level is increasing. It is increasing and then it comes stable. If you see atorvastatin, there is a downsloping. At first it is increased, and then so it is not recommended to increasing the HDL, and that is the reason that in the books and other societies don't talk about the HDL and the statin levels. But rosuvastatin, according to Stellar trial, it is evident that it causes increase in the HDL as compared to the other statins. The trend of the pravastatin, if you say it comes in 2 mgs and 4 mgs, you see that there is a linear increase in the HDL. But the main focus is here the low dose safety profile, and also a low dose, the safety profile, and increase in the HDL. So rosuvastatin is better. This graph is comparing the triglycerides. Actually, statins are not meant for triglycerides. Statins basically focus on LDL, but it has some effect on TGs. For TGs, fibrates are much more recommended as compared to the statins, but statins still do something. Statins in combination with acetamide is a good option as compared to statins combination with the fibrates. In this graph, we focused on TGs. This is the Stellar trial. In this graph, they focused on TGs. Here you don't compare this rosuvastatin with the atorvastatin. Both are giving the same results, almost same results for the triglycerides. You compare it with simvastatin and you compare with pravastatin. So rosuvastatin has a much good profile on low doses as compared to the other drugs for the change in the TG level. So LDL level, rosuvastatin low dose is best. For HDL, rosuvastatin comparable to the other statins is good. and 40 Gs, still rosuvastatin is better as compared to the simvastatin and pravastatin. One of the nowadays inflammatory markers have changed. In recent times, it was said that if the patient they really focused on the LDLs, HDLs, and VLDLs. Now new things are coming up. They are now focusing on the inflammatory markers like CRP, HSCRP, high sensitivity. CRP, then it's fibrinogen, another thing, and there are some other inflammatory markers which are coming into existence, and we are measuring it nowadays. CRP is equivalent to the LDL. So here in this trial, they focused on the CRP, and they said that the statins after the 8 weeks have much good result as compared to atorvastatin in reducing the CRP. CRP level is correlated directly to the risk of the cardiovascular disease. So if you reduce the CRP, there is a reduction in the cardiovascular disease. At 8 weeks, 10 mg rosuvastatin, at 16 weeks, 20 mg rosuvastatin. It is a much difference as compared to the atorvastatin. Now, which is the most effective? First of all, we cover about the dosage, that what dose is effective in other type of things. Here we will see which statin is effective as compared to the other. So we come to another trial which is known as asteroid trial. Asteroid means a study to evaluate the effect of rosuvastatin on intravascular ultrasound derived coronary atheroma burden. First of all, I will tell you that IVUS or intravascular ultrasound, it is basically it gives you the exact atherosclerotic burden which is present in the coronary artery and which is responsible for the coronary artery disease. Two things are very much needed before discussing these steroids. Steroid trial, before discussing the steroid trial, I want to clear about two things. One is that if you go for intravascular ultrasound, measure two things. One is the circumference and one is the external elastic membrane. And if you combine both of them, you will come with the volume of the atherosclerosis, and this is the main focus of any type of medication to reduce it. In steroid trials, a large number of patients, about 1,182 patients were enrolled, and they were followed for about 2 years. And IVUS were done on them, intravascular ultrasound was done on them, and they looked for the atherosclerotic burden in the form of atherosclerotic volume, and they looked for the changes with statins, rosuvastatin as compared to the others, that which is effective, and this is very accurate. In this study, they included the patients who are having coronary artery stenosis of more than 20% and about 50% on the intravascular ultrasound. So these are the stenosis in which angioplasty is not recommended. So angioplasty is not recommended. So on that thing, they basically intervene. So whether statins are working or not. Here I've already told you that you have to focus on two things. One is atheroma area, the red one is the lumen, the yellow one is the atheroma area, and the external elastic membrane area. External elastic membrane area and atheroma areas both are the main focus of this steroid study, and they looked how it reduced, because if both of them are reduced, then there is reduction in the volume of the atherosclerosis. So this was the result of the IVUS study or the steroid study. If you see that in the bottom, if you focus on the bottom pictures, you see that the atheroma was 10.63 mm before the study started. They followed the patient on maximum dose of rosuvastatin above 40 mg, and the atheroma was reduced to 6.99 mm squares, or the area. Elastic membrane, external elastic membrane was 19.05 and it reduced to 17.31, and the lumen size increased from 8.42 to 10.32. Remember, these are the patients in which there was no coronary intervention done. These are the patients in which no stenting was done. and these were the patients who were having coronary artery disease and were given the maximum dose of the rosuvastatin, that is 40 mg, and followed for 2 years. So there is a quite significant reduction in the atheroma, atherosclerotic volume, external elastic membrane area, about 53% reduction of the LDL and 14% increase in the HDL. And I told you that 1% reduction in LDL is equivalent to 1% reduction in the CHD. So 53% reduction means that you are halving the risk factors for the coronary artery disease, and on the other side you are 14% increasing the HDL. So if you calculate both of them, are about 67%, which is quite a huge number if you consider this vast study. So steroid is that study which is showing you that high dose statins are better as compared to the other high dose statins. Now these are the comparison of different studies. Reversal trial was on pravastatin, Camelot was on placebo, Activate trial was also, reversal trial was on atorvastatin. They all looked for the same thing, that is the atherosclerotic volume, and you see that the regression was only with the high dose of the rosuvastatin as compared to the other things, and this was for the mean LDL. Now, if the patient is on the treatment and there is a reduction in the LDL, you also see the steroid trial is saying that high dose rosuvastatin is much better as compared to the other statins. So this is the same thing. We are not going into the detail of that thing. Now here, this is a coronary artery, and if you see from the left to the right, you see the artery is open, then there is atherosclerotic burden increasing, and at the end there is complete stenosis. Here we are going to compare the two trials. One is known as Meteor and other is known as the steroid. The Meteor focused on less disease burden, whereas steroid focused on more disease burden. Both of them went for the high dose statins, and it was obvious that statins high dose was much better as compared to rosuvastatin was much better as compared to the other. This is the same thing as I already told you, Meteor and steroid, early disease, established disease. So steroid has much significant as compared to the Meteor trial, and that was the main thing which caused the FDA to approve 40 mg of rosuvastatin as compared to the other. We talked about the levels, we talked about the dosage, we talked about pharmacokinetics, we talked about its effect on LDLs, we talked about effect on PGs, VLDLs and HDLs and the dosages. Now, what is tolerability and safety? This is the main focus. We are very much concerned about our patients. If we go for high dose, we are always reluctant to go for high dose, like 40 mg rosuvastatin is not very much used. We mainly focus on 20 mg and like this, but 40 mg can be given. So we will focus on the tolerability and the safety. Does it cut myalgia? Does it cause the problems in the liver, or it affects the CKD? If you see that, as I've already told you, yes, there are cases of myopathy on the patient having high dose of these statins, but it is reported about less than 0.1%, which is not that much significant. But for a patient who develops this, yes, it is significant. Otherwise, there is very low chance of developing the myopathy with 40 mg of the rosuvastatin. And this is the graph which is showing which type of statin is causing the muscle problems. If you say simvastatin was stopped because of this myopathy problem, and this was withdrawn, simvastatin was withdrawn from the market after having this type of graph. If you see, rosuvastatin and atorvastatin are almost comparable in compared to for the CK levels or the rhabdomyolysis or the myopathies, but still the safety profile of the rosuvastatin is much better as compared to the atorvastatin. Liver enzymes, I already told you that it causes some time of effect, but most of the patients are well tolerable to the high dose of the rosuvastatin, and the liver functions are deranged on about 0.2%, which is very low, and there is nothing to worry if the patient develops increase in the liver function. Stop the statin, the liver functions will come back to normal, and then you can start with the low dose. So nothing to worry. It does not cause burning of these statins, like burning of the liver, like other drugs. So rosuvastatin is also safe in this time. Patients are the doctors are always asking, what is the effect of statins on the renal artery disease. Actually, this was a trial which is known as Jupiter trial. If you are all well known about the Jupiter trial, which was done in the UK, USA, and a lot of people, especially diabetics and nephropathic patients, were included in the trial. This is the part of it. This is the extension of the Jupiter trial. In this, they took patients with the moderate CKD or patients having reduced ejection fraction in the moderate level, and they started the patient on the high dose statins. And what they found is that there is 45% reduction in the myocardial infarction or cardiovascular diseases like MIs, strokes, peripheral arterial diseases for the patients who are having moderate CKD. They compared CKD with placebo, CKD with no CKD with placebo, then CKD with rosuvastatin, and no CKD with rosuvastatin. Ideal combination is patient does not have any kind of renal disease and you start the patient on a statin, the best results you will get. But if the patient is having CKD of moderate type, not severe, moderate type, and you start the patient on the statin, it has a benefit about 45% reduction in the myocardial infarction. So we come to the end of our study and we come to the end of our presentation. I would like to summarize my presentation that cholesterol and bad cholesterol is always the first enemy for a doctor and a patient. Because of our sedentary lifestyle and because of increase in the technology, we are not that much active like our forefathers. So this is the one thing which is causing increase in atherosclerotic burden, causing increase in the waist circumference, causing increase in the circumference of the neck. And this is directly related to the LDL level, and the LDL level is directly related to the coronary artery disease. So high cholesterol is associated with the coronary artery disease. Rosuvastatin is recommended by AHA guidelines. High dose statins to reduce the LDL to 50% is recommended for every coronary artery disease or cardiovascular disease. For diabetics, moderate intensity, and if it is more than 20% of the risk factors, go for high intensity rosuvastatin. And hepatoselectivity HMG-CoA reductase inhibitor. It is superior in reduction of the LDL. It is comparable in reduction of the TGs. It is superior in reduction of the C-reactive proteins. It is comparable in increasing the HDL to the other statins. It achieves your goal in low doses. It has a safety profile. It causes low risk of side effects, low myopathies, low liver function derangements, and it is a better profile in compared to for the patients who are having chronic kidney diseases. So it comes to the end of this presentation. If you have any type of question, you can ask now. Thank you.
Thank you very much, Dr. Umair.